Good evening, everyone. How are you all? Okay, so we're going to do orthopedics today. So, orthopedics, there are two classes that we normally take, but still it becomes quite difficult for us to finish everything in the class just because there is a lot. Okay, so we'll try our best to finish most of it in the two classes, but make sure that if like you might feel overwhelmed because a lot of these topics you have never even heard of, and sometimes ortho is not like usually very like either you are an orthopedic surgeon, you normally don't know too much of it, right? So we are going to cover orthopedics mainly from John Murtagh. John Murtagh has got like a huge amount of orthopedic chapters, so most of those are in this note. Few of them we will mainly cover from JAM. So first one that we are going to start today, that's going to be from John Murtagh, which is your fractures and dislocations. Okay. So you can open up the chapter 1 to 4 from John Murtagh, and we will start from here today because this is the main chapter for orthopedics. And after that, we will go to musculoskeletal system one by one. Okay, let's start. So first of all, base of the skull fracture. Yeah, so unless we say it is any other edition, if we are talking about GEM, it is always GEM 8th edition because that's the updated edition. Okay, so base of the skull fracture. So So we are now talking about the skull fracture, right? So if we see over here, as part of base of the skull fracture, it is indicated by few specific signs and symptoms. So patient who has got a head injury or trauma to the head, maybe after motor vehicle accident, if they're coming with bleeding from the nose, ears, so we call it CSF rhinorrhea or CSF otorrhea, or if they have got these raccoon eyes, which is like kind of a bruising around the eyes, and also there is a sign called battle sign, which is ecchymosis or bruising on the mastoid bone. So if a patient with a head injury having those signs, raccoon eyes, battle sign, CSF rhinorrhea or otorrhea, then you would think of that this might be a case of base of the skull fracture. So first of all, you need to do a CT or MRI to diagnose it. And after that, once you can confirm that yes, this is a base of the skull fracture, then the treatment of basal fracture is based on looking for any kind of intracranial infection. So that's how we mainly treat base of the skull fracture. First, make sure there is no sign of infection. Avoid excessive interference with the nose or ear. So ask the patient not to blow their nose a lot. Avoid packing NG tube. There is no role of antibiotic prophylaxis. Unless patient having sign of infection, we don't need to give the antibiotic. Okay. And base of the skull fracture, mainly symptomatic management. If it is bad, you might need to even talk to a neurosurgeon about it. Not super important. So then we go for malar fracture. Malar fracture is important. So all of you know the zygomatic maxillary complex. So this is the zygomatic maxillary complex, right? Or commonly known as malar bone. So many times patient who has contact sports injury, or maybe from a fight with someone punched on the face, they can have fracture of this malar bone. So what are the features? So patient can come to you with a swollen face or cheek. They can also get circumocular hematoma. So sometimes they can have a hematoma around their eyes, subconjunctival hemorrhage, You can even get a palpable step in deformity in the infraorbital margin. So this is the infraorbital margin, right? So sometimes if it is a bad fracture, you can even feel the fracture. Flat malar eminence, paresthesia due to infraorbital nerve injury. So just along the malar bone, the infraorbital nerve passes through, and if malar fracture injured the infraorbital nerve, then patient can get paresthesia or loss of sensation on that side of the face. The question that comes in the exam, they ask for what is the most common symptom or what is the most important symptom in a malar fracture patient. So most important or most common one is this paresthesia due to infraorbital nerve injury. And patient even sometimes you need your malar bone to open and close your mouth. So sometimes patient with this fracture, because of pain, they can have difficulty opening their mouth. So how we manage, we make sure patient did not get any head injury. We also rule out any fracture of the orbit. We rule out ocular trauma. So definitely we check visual acuity, we check for any double vision and retinal hemorrhage. If there is a fracture and if the fracture is displaced fracture, then we will refer the patient for reduction under general anesthesia. If it is not displaced, then sometimes even it could be a conservative management by the maxillofacial surgeon. Okay, so treatment is not the most important one that comes in exam. It's mainly about sometimes they would provide you with a picture or a X-ray of the fracture, not this one, but the other ones, and they ask you what's this fracture called? Some of the fracture you need to know the management as well. But for malar fracture, all you need to know what are the signs and symptoms that you can find in this patient. Mandibular fracture is not needed. Dislocated jaw is not needed. Thoracolumbar fracture. Let's talk about this. Thoracolumbar fracture is patients sometimes they can get vertebral fracture, right? And vertebral fracture we divide as stable fracture and unstable fracture. So what are stable back fracture? Stable fracture means that if a patient has got compression fracture of the vertebra with less than 50% loss of their height. So a compression fracture is one of the most important fracture that we need to rule out in a vertebral fracture. And compression fracture mainly happens in elderly patient who can suffer from osteoporosis, which has high risk of fracture anyway. And if it is just a minor fracture, then it's also stable. For a stable fracture, patient just need to be on bed rest for several weeks. They can also put on a back brace. Okay? Patient who gets this lumbar or thoracic vertebral fracture, the complication that can happen that if patient has got a L1 fracture, it can cause kidney injury. Sometimes patient can have paralytic ileus, retroperitoneal hematoma. These are not very important, but any lower fracture like L1 fracture can be associated with kidney rupture or kidney injury. So you need to ask the patient if the patient is like having any kind of hematuria. Burst fracture and shearing fracture are unstable, and for this patient, urgent referral will be needed. So questions come from this thoracolumbar fracture. So they give you a patient and then they give you a picture of compression fracture on a X-ray, and then they ask you what is the next step of management. If it is any kind of fracture, your first management is analgesia. So give painkiller because patient will be in a lot of pain. Okay? Unless if their patient is like that, like there is vascular injury symptoms or there is symptoms of nerve injury, and patient need immediate reduction of the fracture, because without reduction it's putting pressure on the vessel and patient getting ischemic pain, At that time, you need to do the reduction first. Otherwise, in every other fracture case, we go for painkiller first. Okay? So analgesics is the main management, or you can say it's the initial management for any kind of fracture. Now, for thoracolumbar fracture, especially if it is a compression fracture, this is the only back pain where we ask the patient to take rest. None of the other back pain, we will ask the patient to take complete bed rest. We will discuss back pain just after this chapter, so you will know. But this is the only cause of back pain where we ask the patient to take bed rest. Okay, so bed rest has to be done, and back brace, so they can put on this back brace. And also, because one of the most common cause of thoracolumbar fracture is compression fracture, you need to, once the patient is bit stable, you also send the patient for a bone density scan or a DEXA scan, and that can confirm if the patient has got osteoporosis or not. Okay? So how compression fracture looks like in X-ray? So if you look over here, you can see very easily. So see this one. So this vertebra, the vertebra height is normal. This one is also normal. But if you look on this vertebra, see this vertebra having loss of height, that's compression fracture. Okay? So that's how compression fracture usually will present. Moving on, fracture rib. Fracture rib, you know already, we discussed about that in our surgical class, so you can go through that. A simple rib fracture can be extremely painful. So first strategy is to prescribe analgesics such as paracetamol, encourage deep breathing. Sometimes even if needed, we can go for intercostal nerve block. Oh, what's happening? Just 1 second, guys. The adduct is just working funny. Okay, both need bed rest. Unstable fracture sometimes might even need a like an urgent operation, okay, or urgent reduction, or sometimes even putting some screws and everything. Okay. All right, moving on to clavicular fracture. So fracture clavicle also very important. It comes in exam, one of the most commonly asked fracture. So if patient fall on outstretched hand, then they can have this fracture. What the patient will come to you, that patient will have either a direct blow to the clavicle, or they can even have an injury or a fall. Patient will have a extreme shoulder pain. They might also support their arm at their elbow, and they will not move their arm on that side. Okay. The commonest site of clavicular fracture is the middle third. So middle third is the main area where patient get a clavicular fracture. Okay. With a clavicular fracture, you need to rule out likelihood of any neurovascular injury. So what's the nerve which is at risk? The C5 nerve or axillary nerve. So C5 nerve can get injured. So patient can have difficulty with shoulder abduction. And what artery can get injured? Axillary artery can get injured. So we check the radial pulse in this patient just to make sure that they haven't injured any of the arteries. And sometimes clavicle fracture, patient can injure the lungs, and it can also get complicated with a pneumothorax. So we need to make sure there is no neurovascular injury, there is no injury of the lung. Okay. So what is the treatment for fracture clavicle? Treatment for fracture clavicle is arm sling. So you put the patient on a sling for 3 to 6 weeks. Ideally 3 weeks is enough. So you can put them on St. John's sling, or even sometimes a figure of 8 band-aids. So healing time for clavicle fracture is 4 to 8 weeks. Now this is where they have given the specific name of the sling, so you need to remember it. For fracture clavicle, the sling that we use is St. John's sling. For fracture neck of the humerus, it is the same sling. Fracture scapula or forearm, we use broad arm sling. Fracture shaft of the humerus, it's collar and cuff. So you can remember the common one: shaft of the humerus, fracture neck of the humerus, and fracture clavicle. These are common. So just remember the cuff that we use in these patients. Now, fracture clavicle, you need to go through a little bit more. So I will show you. For orthopedics, if you actually want to go through some things, then ortho bullet will be the best one. So let's write fracture clavicle, ortho bullets. So in the ortho bullet, you will learn a lot of things. So in here, you can see that clavicle fracture, like a distal clavicle fracture management and clavicle fracture mid shaft. So both of them are important for you to go through a little bit. So you can see from here that this is the fracture clavicle and it's in the middle third of it. And you can see it's not even full fracture, right? So it's not a displaced fracture. Whereas this one is quite displaced. And you can see that they put some pins and screws also. So mid-shaft clavicle fracture is the commonest clavicle fracture. One of the things that we look into these patients, so especially if a patient has got clavicle fracture, is that if there is any step-in deformity. So what is the step deformity? Let's see if they have shown any picture. No, they haven't. I'll show you in another picture that what is a step deformity. But let's have a look at how we manage mid-shaft clavicle fracture. Always remember that most of these patients who has mid-shaft fracture, they will need just sling. Sling is the main treatment for clavicle fracture, especially middle third. But there are lots of ins and out in it, so you can go through this guideline to have some more idea. So this is the skin tenting I was talking about. If you see skin tenting like that, it is definitely a displaced clavicle fracture, and this needs reduction and surgical correction. Okay. Treatment. So treatment for clavicle fracture is important. It comes in exam. So most of the time it is just sling. So the indication of sling is if there is less than 2 centimeter shortening and displacement. So if the displacement of the two fractured bone is less than 2 centimeter, and it's a closed wound, so it's not an open wound, no neurovascular injury, for them sling is all that you need to do. So let's have a look. So this one, you can see that less than 100% displacement, right? For less than 100% displacement, that means which is not fully displaced, non-operative is the main treatment. That means just put the patient in sling. Whereas this one will need a reduction followed by surgery, because this is definitely more than 100% displacement, because there is no bone-to-bone touch. When we need to go for open reduction and internal fixation, open reduction is needed for mid-shaft clavicle fracture, especially if it is an open fracture. If it is a displaced fracture with skin tenting, as we said, if there is any neurovascular injury, then ideally we will need to go for open reduction and internal fixation. Okay? So remember one thing, that if it is fully displaced, even sometimes, so even if it is fully displaced like this, even sometimes if we can do reduction and put the bone to bone together, then even on that sometimes we go for sling without putting anything inside. So that happens. So middle shaft fracture, most of the time your answer will be just sling. Unless it is like this, in those cases we go for reduction. Okay? And definitely any open fracture will need open reduction and internal fixation. And for clavicle fracture, skin tenting, neurovascular injury will need open reduction as well. What didn't you understand, Dr. Faria or Dr. FK? Didn't understand the question? Can you guys, when you write something, just write in detail that this is what I didn't understand, so that I don't need to ask you. Okay, indication for open reduction. So that now see that it is easy for me to understand what you guys are asking. So if you write in that way, that will be better. So for open reduction, the main is these things. So open fracture, displaced fracture with skin tenting, and if there is any neurovascular injury. So that's the absolute indication. There is a relative and controversial indication, is that if it is a displaced fracture with more than 2 centimeter shortening, which means that if there is more than 2 centimeter gap between the displaced bone, then sometimes we might need to go for open reduction and internal fixation. Okay? But if you have seen something like that in the exam, like this one, this usually need a open reduction and internal fixation, because sling will not fix this. Okay? And also there is some guideline on the ortho bullet about distal clavicle fracture. That's on the ortho bullet that I have shown you. Please go through that in your own time as well. Okay, so fracture of the scapula is not important. AC joint dislocation or subluxation. So acromioclavicular joint is over here. Again, sometimes AC joint can get dislocated if the patient falls on the outstretched arm. Not very important for the exam. The thing is that if there is a AC joint dislocation, the treatment is same. Painkiller, put the patient on a St. John's high sling, and that's mainly the treatment of choice. So it doesn't come in exam, so not important. Shoulder dislocation. So Shoulder dislocation, again, the mechanism of injury is same. So patient can fall on the outstretched hand. Sometimes patient can have like a maybe just direct violent impact on the shoulder can cause a shoulder dislocation. 95% cases it is anterior dislocation where the shoulder moves forward. And few cases, especially if a patient has got epileptic seizure and then comes with a shoulder dislocation, then most of the time it comes as a posterior dislocation. Okay? And posterior means backward dislocation. So if the shoulder moves forward to the joint, that's anterior dislocation, and if it goes backward towards to the joint, that's posterior dislocation. Let's have a look on a X-ray how shoulder dislocation looks like. So this is anterior shoulder dislocation. Definitely you can understand that this is the shoulder joint, right? And this is where the shoulder, the humerus should be. And you can see the humerus is dislocated forward or anterior. So that's anterior dislocation of the shoulder. Okay. So what to do for anterior dislocation of shoulder? You just need to relocate the shoulder. So you'll first diagnose the condition with AP and lateral X-ray. And once the X-ray shows, yes, patient has got a dislocation, what will you do? So first of all, you will make sure there is no neurovascular injury before you do the reduction. And reduction usually, the one that you can do it under general anesthesia, or also you can put the patient on IV morphine and diazepam. Okay, but many times if it is like really painful, you just put the patient under sleep and then relocate the shoulder joint. How to do the relocation? It doesn't come in exam. So all you need to know is provide painkiller, get the patient to do a X-ray, make sure there is no neurovascular injury, and then relocate either by general anesthesia or under morphine and diazepam. Posterior dislocation, as I say, that it's mainly happen most commonly misdiagnosed major joint dislocation. It mainly happens after epileptic seizure or electric shock. Okay? Not important, doesn't come in exam that much. Just remember what I say. Moving on to fracture greater tuberosity of the humerus. So now we are going into the humerus fracture. It's again causing this issue. Let me just open this John Muttag again. I don't know why it's happening like that. So you guys are understanding so far? You don't have any queries? Okay, sorry, I think John Murtag or the Adobe Acrobat is doing some problem today. So we are on this fracture neck of the humerus. So humerus fracture comes in exam, but the only thing that actually needed to know is that what's the management of it. So if you look on this picture, that's where they have given all the management. Oh, again, it's doing the same thing. Okay, let's continue in this way. So there is a picture in here, which I don't know why it's not showing here, but the picture is the most easiest one to go through. So on that picture, you would see that different fracture has got different kind of management. And that's all that actually you need to know from this humerus fracture. But I will go through this from here. So if there is a fracture of the greater tuberosity of the humerus, the treatment is immediate immobilization and rest in a sling unless it is grossly displaced. So for fracture greater tuberosity of the humerus, now I have to show you all of them, which will take a lot of time, unfortunately. So see that this is the greater tuberosity of the humerus. So if there is a fracture on that area, most of the time all you need to do is to put the patient in a sling. And then this is the neck of the humerus. Okay, sorry, this is the neck of the humerus, and that's the shaft of the humerus. Okay? So for greater tuberosity of the humerus fracture, mainly the treatment will be immobilization in a sling. For surgical neck of the humerus fracture, so if the neck of the humerus has got fracture, again the treatment is the same. So you put the patient in a triangular sling, and when the pain subsides, then gradually patient can start going to the physiotherapist. And usually healing of upper limb fracture takes 4 weeks. So what is the pitfall with fracture of the surgical neck of the humerus? So minimally displaced fracture of the surgical neck are usually managed conservatively, but many times if patient start moving before the fracture has healed, it can cause non-union very easily. Okay? So normally we don't ask the patient to do too much of a movement before 4 weeks. And for surgical neck of the humerus fracture, so if I show you a picture, then you would understand. So you can see that this is the neck of the humerus fracture. For neck of the humerus fracture, the problem that can happen that the radial nerve can get injured. So watch for any radial nerve palsy for such a patient. Okay. Okay. So the condylar fractures are not very important, but supracondylar fracture is very important. So if you see that this is the elbow joint, and in the elbow joint, that's the end of the humerus, and then you have got radius and the ulna. So this is medial condyle and this is lateral condyle. So fracture of the condyle does not come in exam that much, but just above the condyle, if there is a fracture, that's supracondylar fracture. Now this is a very important fracture, commonly happens in children, but it comes in exam as well. It's an important one to know. So for children, one of the most dangerous fracture and potentially deforming fracture is supracondylar fracture. Okay. So supracondylar fracture present about half of all elbow fracture in children, and most of them fall onto their outstretched arm. So what will happen that if there is a supracondylar fracture, because around the elbow joint there is a lot of arteries, nerves and everything, but the most important thing that we need to make sure is that brachial artery injury. So sometimes when there is a supracondylar fracture, the displaced bony fragment can cause impingement on the brachial artery. And if brachial artery gets pressure, patient can get compartment syndrome. So the part of the arm or part of the forearm which is supplied by the brachial artery will not get enough blood supply, which is the forearm flexor muscles. So this patient can complain is very severe forearm pain. So always make sure if a child or if someone has got supracondylar fracture and they are complaining, even after treating the fracture, patient complaining a severe pain on their forearm muscle, you would make sure that the brachial artery has not got injured, because that's one of the most important thing to rule out. This can also cause radial nerve, median nerve, and ulnar nerve injury. That's why this is bad, because lots of nerves and arteries are there. So brachial pulse and radial pulse should be assessed in this patient. So how to manage this or how to treat supracondylar fracture? Supracondylar fracture needs to be reduced by hyperflexion of the elbow during traction. So for this case, you will need to, it's just not doing really good, right? So this fracture needs to be reduced. So once reduction is done, then it will be immobilized in a collar and cuff. Because there is already a risk of ischemia, you don't put this patient on any kind of plaster casting. Even though it is a bad fracture, you don't put this patient on a cast, because plaster cast sometimes can increase the risk of this ischemia. So if you are reducing and then putting the patient in a collar and cuff, you need to make sure you follow up the child like almost every hour in the first 24 hours for any circulatory compromise. Especially you need to check the brachial pulse and radial pulse. And the collar and cuff should be used for 6 weeks. So that's the management of supracondylar fracture. Very important, comes in exam. Fracture of the radius and ulnar shaft. So fracture radius ulnar is not very important, doesn't come in exam that much, but you need to just know the common management of this fracture. So if the radius or ulnar shaft got fractured, if it is a displaced fracture, it will require reduction and then plating. Okay. Let me show you how it will look like. So most of the time, if someone has got a bad injury on their forearm, most of the time that both of these bone fracture. Having just one bone fracture is not common. So you can see the shaft of the radius and ulna has both got fracture. So for something like that, they would need a reduction and then put a plate in. And what is the healing time of it? So for patients with spiral fracture, 6 weeks, and for transverse fracture, 12 weeks for radius and ulna. Now, very, very important is Colles fracture. So Colles fracture is one of the most common fracture, especially in elderly patient. So Colles fracture is fracture of the distal 3 centimeter of the radius caused by fall onto the outstretched hand. So if a patient fall on the outstretched hand and there is a fracture in the distal 3 centimeter of the radius, that's what we call as Colles fracture. So common in elderly women, most of them are already having osteoporosis. There is a specific feature of Colles fracture. So you can see there is an angulation that's very important. So patient who gets Colles fracture, they have this dinner fork deformity. And the dinner fork deformity is, you can see that the fracture, the distal fracture is posteriorly displaced, and then there is a slight angulation. So it's called posterior and lateral displacement. Okay? So posterior and lateral displacement, and then there is a dinner fork deformity like this. That's the time we call it Colles fracture. Okay? So what will be the management for Colles fracture? For Colles fracture, if it is minimally displaced, so there is bone-to-bone touch is there, which is not common to have, but if it is minimally displaced, then we just need to put the patient on a below elbow plaster cast. Okay, so you put the patient on a below elbow plaster for 4 weeks and then a crib bandage. And that is how it looks like. So you can see it's a below elbow plaster cast. Now, how we position this cast comes in exam sometimes. So we put the wrist in a 10-degree flexion, 10-degree ulnar deviation, and pronation. So easily you can remember by writing FUP. So FUP means flexion, ulnar deviation, and pronation. So that's how we mainly do the plaster casting, which is a below elbow plaster cast for Colles fracture. And this has to be there for at least 4 to 6 weeks. So what are the complications that can happen with Colles fracture? Colles fracture, because it's around the wrist, sometimes it can rupture the extensor pollicis longus tendon. So that's the tendon which helps to extend the thumb. So extensor pollicis longus tendon can get ruptured. So if a patient who has got a Colles fracture and suddenly can't extend the thumb, you would look for this tendon injury. They can have stiffness of the joint, especially the wrist joint, and they can also have an ongoing pain over there. Next, so we are mainly discussing all the important fracture, not the unimportant ones. Okay, so Colles fracture is super important, and you need to know how to diagnose this by an X-ray. So let's have a look. This is a classic picture. You can see that this is common, like the best picture of the dinner fork deformity, right? So you can see that posterior and lateral displacement, and with a bit of angulation. And also it's the fracture of the distal 3 centimeter of the radius. Okay. And if you see like this, that's also Colles fracture, because this is minimally displaced. And you can't see the displacement sometimes on the AP view. So if you do a lateral view, then you should be able to see the displacement much better, like this one. Scaphoid fracture, another very fracture that comes in exam. So among all the carpal bone fractures, so you can see that this is the radius and this is the ulna, and then this is the carpal bones, which is what forms the wrist joint. There are lots of carpal bone, but the scaphoid one is the most important one. Okay, so just at the base of the thumb, okay, at the base of the thumb, you get your scaphoid bone. So this scaphoid fracture is almost 70%, 75% of all the carpal bone fracture. Scaphoid fracture is the common. It's rare in children and elderly, but middle-aged active patients usually get it by falling on their outstretched hand. So how a scaphoid fracture patient will present to you? Think about a fracture at the base of the thumb. So what will happen? Base of the thumb means patient will have wrist pain. So patient will have pain on the lateral side of the wrist. They will have pain on the anatomical snap box. So that's the most important feature of a scaphoid fracture. Let me show you. So this is thumb, and that's the base of the thumb, and you can see that that's where you get your scaphoid bone. So if a patient has got tenderness in this anatomical snap box, there is wrist pain, especially on the lateral aspect of the wrist, you would think of possibility of a scaphoid bone fracture. Now, there is a chance that even if it is a scaphoid fracture, 20% cases in the initial X-ray, there might not be any fracture. So there is 20% rate of false positive report of a scaphoid fracture. And sometimes there is also false negative report. So there might be a fracture, but X-ray will say there is no fracture. So clinical diagnosis is very important. So someone who has got a fall on their hand, complaining pain on the wrist, especially on the lateral side or base of the thumb, and there is tenderness on the anatomical snap box, even if the initial X-ray says that there is no fracture, you will treat the patient as a scaphoid fracture. So if a scaphoid fracture is highly suspected in the presence of a normal X-ray, you would immobilize the wrist in a scaphoid plaster for 10 days. Okay, so this is a scaphoid plaster. It's also a below elbow plaster, but it will involve the thumb up to the palmar crease or up to the knuckle. So this below elbow plaster has to be put on, and after 10 days, you will remove the cast and do a repeat X-ray. And sometimes if the initial X-ray comes negative, then after 10 days, the X-ray can come back positive. Let's say after 10 days when you did the X-ray, still there is no fracture, but patient is still having the pain. In that case, only way to confirm the fracture is to get a bone scan. Okay, so you can do a bone scan to confirm the scaphoid fracture. For undisplaced and stable fracture, 6 to 8 weeks in a below elbow scaphoid cast is usually the treatment. If it is displaced fracture, it might even require reduction and internal fixation. But most of the treatment will be like this, below elbow scaphoid cast. Yeah, if it is a displaced, any displaced fracture will usually require reduction and fixation. And Colles fracture is the same. Are there any other significant thing that can happen in snap box other than fracture? That's the area of the radial nerve also. So a patient can also have injured their radial nerve. So that's another thing that you have to look into. thumb fracture doesn't come in exam, but metacarpal fracture comes in exam. Okay, let me open the JM again. It's just not showing things that I really need to show you. It's never happened this in the past. Is it only happening on my side or your side also? Are you guys also having difficulty to open the John Mood type? Or it might be just my side? Why the error is happening? Okay. Don't know. It's just not a good thing to happen. I'll see what can be done after the class, but definitely let's continue. Okay, so we finished the scaphoid fracture. Moving into metacarpal fracture, right? So metacarpal fracture, it comes in exam, but not super important. So sometimes if a patient punched someone or punched into a wall, they can come up with a metacarpal fracture. The common fracture is like fracture of the fourth and fifth metacarpal. Most metacarpal fracture are treated by correcting the displacement with manipulation and splinting with a below elbow padded posterior plaster slab. So you can have a look on the picture if it shows. So if you're looking into the picture, you would know that what they're talking about. So basically most of the metacarpal fracture will need a reduction, and then you'll need to put the patient on a posterior plaster slab. Okay, so that's important to remember because a lot of people think that just because metacarpal fracture, you just put the patient in a sling, but it's not the case. So let's have a look. So metacarpal fracture looks like this. So this is the metacarpal bone, as you can understand. So for metacarpal fracture, you will need to reduce it if it's needed. If it is well aligned, then there is no need. But if it is displaced fracture, you need to reduce it and then put the patient on a posterior slab. So this is something like a posterior slab. That's commonly that usually we do. Okay. So dislocated fingers doesn't come in exam. So that's mostly all the upper limb fracture. Okay. Any questions so far, guys? I'll take a 10-minute break and we'll see that if I can fix up this issue that's happening with John Motor opening, and then we will start with the lower limb fracture after that. Okay. As I say that if it is displaced fracture, in scaphoid fracture being displaced is not very common because of the surrounding carpal bones. Not very common, but if it is a displaced fracture, it will require open or closed reduction and sometimes even internal fixation. So if it is markedly displaced, any fracture will require reduction and fixation. Thanks, guys. We'll take a 10-minute break now. Thank you. All right, everyone. Seems like everything is good now. So we can continue. So let's start with lower limb fracture. So first of all, injury to the pelvis and hip. Okay. So fracture of the pelvis, we had a discussion in our class that how to manage a fractured pelvis. So definitely fractured pelvis, you need to consider possibility of internal injury as well, right? So a stable pelvic fracture, most of the time it doesn't cause anything like a pelvic organ injury, but unstable fracture it can. So unstable fracture associated with visceral damage or blood loss. So patient should be referred for expert help. But if it is a stable pelvic fracture, most of the time symptomatic management with painkiller and bed rest as the pain symptoms dictate. So usually bed rest for a few days or weeks will do. Femur fracture. So all of you know about neck of femur fracture, which is common in elderly patient, but it's not like only fracture is femoral neck fracture. Femoral shaft fracture can happen. Lots of other fracture can happen on the femur. But femoral neck fracture is the commonest one. No, external pelvic wrapping is mainly done in the unstable ones, not the stable ones, especially if the patient has circulatory collapse. Femoral neck fracture has these three subtypes. One is subcapital, then intertrochanteric, and stress fracture. So if you look over here, that's the fracture of the femur. This is intertrochanteric fracture, as you see. That's the stress fracture, especially in young athlete. And capitus means head. Below the head, the fracture is subcapital fracture. Okay, so these are the main fracture of the neck of the femur. And if you look over here, the usual management is either you do the reduction and put a pin in, or older patient might need a hip replacement in this case. So subcapital fracture are usually treated by putting a pin. Greatly displaced subcapital fracture in the elderly has a risk of femoral head avascular necrosis. So for elderly patient, better to go for a prosthetic replacement. Now, if like a young patient who is athletic complaining of like pain on the hip joint, you have done an X-ray, nothing came up, but still patient is in a lot of pain, and it's like patient can't even run anymore because of the pain. You would not just stop there. You can do a CT scan, and even if CT says everything is normal, the only way to rule out a stress fracture is to do the technetium 99 bone scan. So the only way to confirm a stress fracture is the bone scan. Okay, so if you suspect that there could be a fracture, even if X-ray CT coming normal, you need to send them for a bone scan. And the other fracture you can see, femoral shaft fracture, will need a intramedullary nail. So you need to put a nail in here for shaft fracture. For supracondyle, so this is also condyle, supracondylar fracture of the femur needs internal fixation. And condylar fracture, so if it is a undisplaced condylar fracture, needs plaster. If it is displaced, it needs internal fixation and then a plaster. Okay, so that's the usual management. So what I would suggest you, rather than wasting a lot of time on reading all of those, look at the pictures. Same as the humerus has a fracture picture like this, just go through that picture, remember the usual management of them, and same happens with the femur fracture. Unlike shoulder dislocation, where anterior dislocation is common, for hip, posterior dislocation is common. Okay, so for a dislocated hip, patient will be in a lot of pain also. But the way way to remember or way to know that is it a dislocated hip is by looking at the hip. So it will be painful shortened leg, and the hip will be adducted, medially rotated, and slightly flexed. Let's have a look how a dislocated hip looks like. So if you look at the patient, this is posterior dislocation of the hip. You can see that this side is shortened, and you can see that it's a slightly flexed and medially rotated. So medially rotated, slightly flexed, short leg, and it is painful. That's the time you would think of the hip dislocation. And you can see this one. So this hip is definitely into the right place, but this one, it is, you can see it's posteriorly dislocated. Okay. So how to manage this? So definitely they will be in a lot of pain, adequate analgesia, then do a X-ray to confirm the diagnosis. And this patient will need the reduction of this hip under general anesthesia or under relaxant anesthesia. Once you do the reduction, you need to do a X-ray again to confirm the reduction. Patellar dislocation doesn't come in exam. Fracture of tibia and fibula. Very easy, if just like radius and ulnar fracture, if there is minimal displacement, you just put the patient on a full leg cast. If it is displaced, then you have to do the reduction followed by cast. For this kind of fracture of long bone of the lower limb, it takes even 16 to 18 weeks to heal fully. Fracture fibula is not important. Tibial shaft fracture. Tibial shaft fracture is uncommon in adults but more common in children. A padded cast from the groin to the metatarsal neck is applied. So mainly the whole leg will be in a cast. So same. So tibial shaft fracture and all of this, especially any kind of fractured tibia, most of those patients will go for a full length of the leg casting. Okay? Doesn't come in exam, so don't worry. Stress fracture of the foot, very important. So same athletic patient who runs a lot, jumps a lot. So for those patients, if they're complaining a localized pain on any specific part of the foot, there is localized tenderness and swelling, and you have done a X-ray, the X-ray not showing any fracture, then you have to do a nuclear bone scan to rule out the fracture. Okay. So what we do for stress fracture, most of the stress fracture happens in the navicular bone. It is seen in athletes involved with running and poorly localized mid-foot pain. Plain X-ray is usually normal. This is difficult to manage, but this patient needs to be on a cast for 8 weeks. So that's all about fracture, guys. Okay. So fracture chapter, it is not hard, given that all you need to know is like how to at least get the X-ray. So how to know that what type of fracture it is, and then just the management of it. So I hope that it clear up your understanding about the fracture. Do you guys have any questions on this topic? And the only thing that you really need to go through is what we have discussed. Nothing much actually comes in exam apart from that we discussed. Yes, so X-ray, CT, bone scan. Many times, like even sometimes we can directly go from X-ray to bone scan, but we don't usually go bone scan as our like initial option. So I know we would normally do X-ray. If it's normal, then we go a CT, CT normal, then a bone scan. That's usually the step-by-step approach. And Dr. Faisal, yes, nerve block can be done for the dislocated hip. If there is a fracture with neurovascular injury, then as I say, then reduction is usually the main treatment. So reduction has to be done as soon as possible because most likely the fracture is displaced and it putting a pressure. And Dr. Mitra, you need to show me some example of the questions. I'm sure you're asking from any particular question. If you can show me, then I can answer this question. That because there is no specific like step-by-step management. So we do all of this at the same time. I know the questions sometimes can be quite tricky, but open fracture and wound management, there is a lot of things that we do, right? So we do wound debridement if needed. We also give tetanus immunization, painkiller. So it depends on the full questions, and then we can normally decide about it. Okay, if you show me a specific question, then I will see what the option and how the question is coming, and then we can answer. Okay, moving on to chapter 28, low back pain. Very important, low back pain. There's a lot of questions which come from here. So that's chapter 28. So low back pain, the commonest cause of low back pain is vertebral dysfunction or mechanical low back pain. So that's sometimes asked in the exam that what is the commonest cause of low back pain? So vertebral dysfunction is the main cause. But there are lots of causes of back pain. Some patient can have lumbar degeneration, which is lumbar spondylosis, which can be the cause of back pain, which is common in elderly patients. Serious disorders should not be missed, such as you should not forget that it could be osteomyelitis, which is infection of the bone marrow, tuberculosis of especially immigrants from Asia and Central Africa. We should also remember sudden onset of back pain with fever, chills, IV drug abusers. Think about epidural or subdural abscess. So red flags for back pain. It's very important to know what are the red flags, because if there is a red flag, then we normally need to do a little bit more investigation. Not everyone who comes with back pain, we will just send them for a scan, lots of imaging. There are only this group of patients who might require some form of imaging. And most of the time we start with a X-ray. So age above 50 and less than 20, just because they are more than 50 doesn't put them in a red flag. With this age, there has to be some of the other things. History of cancer, fever, constant pain, especially night pain, is always important to rule out. Unexplained weight loss and significant trauma, neurological deficit, especially progressive neurological deficit like numbness or dead arm, dead legs, that's important. Progressive loss of sensation, progressive weakness, these are always important to rule out. Patients who are IV drug abusers, steroid users, no improvement of the pain after a month, and there is like features of cauda equina syndrome such as like incontinence, saddle anesthesia, like perianal anesthesia. Those are always important red flags. Okay. So any patient who is coming to you with a low back pain, these are the important questions that you need to rule out. And if this is present, you need to do some imaging. Okay. But the first thing that you would do for a low back pain patient is analgesics. So paracetamol is the first line treatment. Okay? So we divide the back pain into inflammatory pain and mechanical pain. There is a way to differentiate between these two. Inflammatory pain gets better with activity. So effect of activity, so it is relieved by activity but get worse with rest. And inflammatory arthritis or inflammatory low back pain, they also have got severe prolonged morning stiffness. And it gets worse in the night and in the early morning. Whereas mechanical pain gets better with rest and worse with activity. And at the end of the day, it gets worse. Okay? So that's how we differentiate mechanical and the inflammatory pain. Lots of things I have written in here from JAM, which you can go through in your own time. But there is a very important summary of guidelines in here. So like, if there is a continuous night and day pain, think of infection or cancer. Sometimes, not always. What is the cancer of the lower back? The primary malignancy of the vertebra is multiple myeloma. Okay, but multiple myeloma is not the commonest cause of cancer in the vertebra. Rather, metastatic cancer is the most common. And the three big metastases are from lung, breast, and prostate. Okay. If a patient complains back pain with standing and get better with sitting, think of spondylolisthesis, which means slipping of one vertebra on the top of other. So if this is one vertebra, the next vertebra should be over here. But if it slipped over, like prolapsed like this, that's spondylolisthesis. If it's a young person having inflammatory back pain characteristic, think of possibility of an ankylosing spondylitis. And osteoarthritis is basically a mechanical pain. So patient's pain will get better with rest and worse with activity. And you can go through these things in your own time. So moving on to vertebral dysfunction, which is the commonest cause of low back pain. So it's mainly happened due to dysfunction of the facet joint of the vertebra. So what happens in vertebral dysfunction is that patient usually complains that there is a insidious onset of low back pain, and the pain can radiate over the sacrum and the buttock. It can also have a history of like lifting or twisting. So patient might be doing some lifting or maybe got a twisting injury on the back, and suddenly there is a localized low back pain, and pain get worse with activity, lifting, gardening, or housework, and gets better with rest. So kind of a mechanical pain. Okay, and it will be a deep aching pain. Patient can also have a localized tenderness on the vertebra. Just because there is a localized tenderness doesn't mean that it is a fracture. Many people have this idea that because one bone is a bit tender means that it is a fracture. It's not like that always. Vertebral dysfunction patient also will have restricted flexion, extension, and lateral rotation. Now, if your patient fulfills the criteria, don't just think that just because JM said it is common between 22 to 55, 60-year-old cannot have vertebral dysfunction. They can have it. It's not uncommon. Okay, but this is common in this age group. So what would you do if a patient having like similar history like this? Would you send the patient for a X-ray or CT scan just because patient is above 50? No. It's not always needed. So it's a clinical diagnosis. Investigation is usually inappropriate. Okay? So diagnosis should be made clinically. Management, patient will continue the activity as directed by the pain. So normal activity is encouraged from outset. So you don't need to put the patient on bed rest for such pain. You can give them some painkiller and most importantly paracetamol. And if needed, then if there is an inflammatory pattern, you can give them a short course of NSAID and then send the patient for exercise program. Okay, but the main treatment will be initially analgesics and advise the patient to continue activity. Radiculopathy. What is radiculopathy? Radiculopathy or radicular pain is it's a nerve root compression from a disc protrusion or a tumor or a narrowed intervertebral foramina. So let's say that this is the vertebra, and in between each vertebra there is a bit of disc, right? And from here the nerve root comes out and supplies the leg. So if there is a disc get prolapsed, it can pinch this nerve, right? And if it pinches this nerve, then the patient will have tingling numbness sensation on this specific nerve, specific dermatome where this nerve is supplying. Like if it is, let's say it is the left L4 nerve root is getting pinched. So you know that L4 supplies the medial part of the leg. So patient will complain pins and needles or tingling numbness sensation on the medial part of the left leg. Okay, so that's radicular pain. So what would you do for this radicular pain, or if the nerve get pinched? This is also known as sciatic pain. So for acute sciatic pain, which means less than 12 weeks duration, the treatment is the same, which means patient can continue activity. You can give them some analgesics. You can send them for exercise physiotherapist. That's the treatment. No need of any imaging. Just because there is a tingling numbness, you don't need to just send them for a CT or MRI. Okay? But if there is a progressive numbness, progressive loss of sensation in a very short period of time, then yes, that patient will need a MRI. So even after 3 months of this treatment, still patient is in pain, then sometimes you can order a MRI for this patient, okay, for radiculopathy patient. But even before that, if you want to do a CT, that's totally fine. CT is also not a bad investigation to look into the nerve roots and everything. All right. If anytime they are asking initial investigation, that's usually X-ray. Even though X-ray cannot say about radiculopathies, initial is usually X-ray. Okay. And the most appropriate is MRI if needed. But most of the exam questions, they will actually ask you to talk about like analgesics and continue activity. Okay. So don't just send the patient for MRI or CT. That's my main concern because that's what most of the people usually choose in the exam. Lumbar spondylosis is wear and tear or degenerative osteoarthritis of the lumbar vertebra, which is common in elderly patients. And for these kind of things, the same treatment, analgesics, continue activity, small period of anti-inflammatories, that's the treatment. Okay. So general aspect of management for back pain, the main aim is to reduce the pain, maintain the function. So advice to stay active is one of the main treatment. Relative rest for acutely painful, debilitating back problem, 2 days of strict rest is optimal. Resting for longer than 3 days does not produce any significant healing. Exercise program as soon as the acute pain settles is a very good idea. Okay. Paracetamol is recommended as the first line analgesics. Always remember that. And then as a second line, when there is a bit of inflammatory pain pattern, you can give them a short period of NSAID. And opioids are not usually recommended for low back pain. And this is the sciatica. So how sciatic pain presents? Sciatic nerve, it starts in the lumbosacral plexus, then it runs through the back of the thigh, and then it goes towards the foot. So if the sciatic nerve gets pinched, then the pain can start from the low back and it can travel like an electric shock like pain can go down towards the foot. Okay, so that's sciatic pain. Same if it is an acute sciatic pain which is less than 12 weeks, the treatment is resume normal activities, paracetamol, NSAID for 10 to 14 days. Okay, and send the patient for some back education program. Now, only time if a patient having radicular pain, like tingling numbness sensation, you would need urgent surgical review. Like you need to make sure you go for a MRI if a patient having bowel or bladder control disturbance, perineal sensation loss, and this usually goes with cauda equina syndrome, or progressive motor disturbance like progressive weakness, progressive numbness, loss of sensation. That's the time you would think of doing a MRI straight away. Otherwise, you would not go for a straight away MRI in any kind of back pain. Does it make sense for everyone, the low back pain? Any question, guys? Even if patient is more than 8-year-old, absolute bed rest is only needed if there is a fracture of the vertebra. Otherwise, absolute bed rest is not needed. And brace is only for compression fracture, not for all the pain. Okay, Dr. Fatima? MRI, as I asked Dr. Shahbab, is that MRI is only needed if you think that the patient has got possibility of a spinal cord compression. And spinal cord compression, the features will be discussed in our neurology class. But if there is a patient with a sudden back pain, having bowel bladder disturbance like incontinence of bowel and bladder, progressive numbness, progressive weakness of the lower leg, okay, for those patients, we go for MRI. Otherwise, no need initially. Lumbar spondylosis, same treatment. So analgesics, and then you can ask the patient to stay active and physiotherapy. They never ask about definitive treatment of back pain. Dr. Akshara, there is no definitive treatment. For every patient, there is a different approach of managing the back pain. Okay, the last management would be surgery. That's the definitive treatment, but usually they would never ask you that what is the definitive treatment. Neck pain. So neck pain is also important. Neck pain, back pain, more or less similar kind of things. The common cause of neck pain is also vertebral dysfunction. Okay. And these are the red flag pointers for neck pain. So patient more or less same. So age more than 50, constant pain, fever, and patient having history of cancer, unexplained weight loss, progressive neurological deficit. These are mainly the red flag pointers. For neck pain, it is a good idea to know the dermatome of the upper limb. So if you look over here, this is the dermatum. So this nerve C5 to T1, this comes from the brachial plexus of the neck, right? So each of these nerves supplies a specific part of our upper arm. So C5 supplies the deltoid muscle. So over here, C6 supplies this whole part, including the middle finger, including the index finger, including the thumb, okay? The middle finger, this part is supplied by C7. Little finger and half of ring finger is C8, and T1 is the upper inner arm. So C5 is the deltoid. C6, you can see the lateral part of the forearm, including the thumb. C7 is the middle finger. C8 is the little finger, and T1 is the inner arm. So that's the sensation of these nerve roots. So if a patient has got C5 nerve impingement, their main pain will be on the deltoid area, right? And this deltoid muscle mainly helps with abduction of the arm. So patient will have difficulty with abduction. So if this is the patient, abduction is moving the arm on their side, okay? And C5, C6 gives the biceps jerk. C6 is mainly, C6 supplies the biceps, and this C6 also helps with elbow flexion and wrist extension. So if someone has got C6 radiculopathy, they can have like lack of power with elbow flexion and wrist extension. C7, as we talked about, middle finger is the main part of C7, but C7 supplies the triceps muscle, and C7 helps with elbow extension. And triceps jerk, the root value is C7 and C8. C8 mainly moves the flexors of the finger. So finger flexion is done by C8. And if finger flexion is lost, patient will lose the grip movement, right? And abduction of the finger, that means finger is spreading, that is done by the T1. Okay, so this is the specific function, like muscle power, like means the motor function and the sensory function of this brachial plexus. Okay, that means C5 to T1. Now this is important because sometimes they give you a scenario, they give you some of these things like patient having weakness of elbow flexion and wrist extension, their biceps jerk is lost. So then you would need to know which nerve has got impinged. Cervical spondylosis is the same thing like lumbar spondylosis. It's a degeneration of the cervical disc and the vertebra. So for cervical spondylosis, patient will have this kind of dull aching pain in the neck, and this patient can have pain worse in the morning, can get improved with gentle activity, but deteriorate with heavy activity. Okay? C6 nerve root is most commonly involved. Sometimes even patient can have like an aggravation of the existing pain. They can have associated vertigo or unsteadiness with the neck problem. So what would you do for cervical spondylosis? Normally, you don't need to do even any kind of imaging for it. If needed, like if the pain is really bad and other red flag is there, then you can do an X-ray. That's it. The treatment will be the same. So reassurance, give some analgesics like paracetamol, and also send the patient for physiotherapy, advice to continue activity as they can. Radiculopathy, same like lumbar radiculopathy. If the cervical nerve roots are getting pinched, they can also get a radiculopathy. How would you know from the stem that they are talking about radicular pain? The complaint is there is a neck pain which is radiating to the arms, and patient complains pins and needles on their finger. If that is the case, then you would think of radiculopathy. Okay. So for radiculopathy, you can see a sharp pain in the neck radiating down to the arms. Sometimes patient can also complain of numbness sensation or loss of sensation in their hand or forearm. They can have nocturnal pain, like pain waking up the patient during night. So if needed, you can do a X-ray, not required before 6 to 8 weeks unless red flag present. Now, that is what I want you guys to understand, that if there is no red flag, even if the patient has got a bit of tingling numbness, doesn't need to have a emergency X-ray or a CT. Unless patient having a progressive numbness, progressive weakness, or there is severe night pain or any other red flags, you don't need to just send the patient for imaging even before 6 to 8 weeks. Okay? So even for radicular pain, the best one would be MRI, especially for a radiculopathy. The treatment is bed rest, analgesics. Even sometimes we can give them a short course of steroid for severe neck radicular pain. You can send the patient for physiotherapy also after the acute pain settles down. What is myelopathy? So that's important. Now, we're talking about nerve pinch. But what if it is severe enough that the degeneration causing multiple immature bone formation, which is osteophyte, and it is causing narrowing of the spinal canal. So if the patient develops a spinal canal getting narrowing, and then somehow they're causing the spinal cord getting pinched. So when cord getting pinched, that's the time patient will develop myelopathy. Okay, so the patient will develop features of cord compression. So for cord compression, the main feature is that definitely patient will have numbness, tingling in the fingers, but most important is sign of upper motor neuron type of palsy. So patient will get spastic weakness of their arms, hypertonia and hyperreflexia. Okay. So definitely if it is a cervical spinal cord compression, patient can get like quadriplegia, especially if it's really bad, that's the thing that can happen. But initially it would start with pins and needles or tingling numbness sensation in the finger, and then eventually if the cord get compressed, they will have spastic paraplegia, that means weakness of the both arm, hypertonia and hyperreflexia. Now if that happens, for that patient you need a urgent MRI scan or a CT with myelogram. Okay. Myelopathy means spinal cord compression. And radiculopathy means nerve compression. That's the easiest way to remember. And the chart for C5, C6, that's in John Mutta, Dr. Memona. You can open up that. So clear, guys, about the neck pain. Okay, moving on to chapter 52, shoulder pain. So you can see that this is the basic shoulder structure, and shoulder joint, you can see that that's definitely the humerus, right? And this one is acromion, that's the one of the bone, and this is clavicle. And that's called AC joint, acromioclavicular joint over here. Just below the acromioclavicular joint, you have got subacromial bursa, right? And this is the supraspinatus tendon. This main tendon, which mainly helps the arm abduction or shoulder abduction, which means raising the arm on the side. So one of the most important thing that we want to rule out in a shoulder pain is rotator cuff tear. And rotator cuff is group of muscle which stabilize your shoulder. The most important muscle is supraspinatus muscle. So you can see in here that abduction is done by supraspinatus tendon. Adduction is done by pectoralis major. Internal rotation done by subscapularis muscle, and external rotation done by infraspinatus muscle. Okay, and teres minor. Now this 4 is rotator cuff muscle. So if there is a tear of any of them, that's rotator cuff tear. Okay, so if you look over here, that these are the 4 muscle or tendon that mainly stabilize our shoulder. So we have got supraspinatus, helps with abduction. Infraspinatus and teres minor helps with external rotation, and subscapularis internal rotation. Better to see a picture which actually explains everything. So if you see that this is the supraspinatus tendon, that's infraspinatus, and that is the spine of the scapula, and then teres minor, and then you have got subscapularis over there. So that's the 4 rotator cuff. Now, when we see a patient who is having difficulty with abduction of the shoulder, we want to find out that what has caused this problem. Now, if you look over here, that the initial 15 degree, so this bit is done by deltoid muscle, and then from 15 to 60 degree, that's done by supraspinatus muscle. From 60 to 120, so that's your scapulohumeral component, so done by serratus anterior and trapezius. And above 120 is done by pectoralis major muscle. You don't need to memorize this, okay? So I want you to understand that if someone has difficulty to raise their shoulder from this 60 to 120 degree, that's called painful arc. And what does it mean is that the subacromial space, so this space is very narrowed in here. Because of narrowed subacromial space, the supraspinatus and everything in here gets pinched. And that's why patient has this difficulty to raise the arm between 60 to 120 degree. And that's called painful arc syndrome. And that mainly happens if the subacromial space is very narrow. Okay. Now, coming to the important one, which is rotator cuff tendinopathy, and that is also called subacromial impingement syndrome. As you can see that they are mainly referring to supraspinatus tendon, because supraspinatus tendon is the main tendon which can get pinched in the subacromial space. So it is the commonest cause of shoulder pain. It can be like the tendon can get inflamed, causing tendonitis, can be a tear in the tendon, can be calcified, a lot of things can happen. but the most common is supraspinatus tendon injury. So when would we think of rotator supraspinatus tendinopathy? So supraspinatus tendinopathy patient will have constant shoulder pain. It's a throbbing pain, can be very severe, constant day and night, and it can happen at any time. So even a little bit of movement can bring the pain. It can be aggravated by putting on the shirt, toilet activity, lying on the shoulder. If you want to confirm the diagnosis, you have to do an ultrasound. So ultrasound can confirm if there is supraspinatus tendinopathy or a tear. So you should think of supraspinatus tendinopathy, especially if the patient is unable to do the shoulder abduction. Okay. So once you confirm the diagnosis, then the treatment will be for supraspinatus tendinopathy. You can start with them paracetamol as first line. If that is inadequate, NSAID can be given as well. And at some point, you can also send them for physiotherapy. Okay, so surgery is only needed if after 3 to 6 months, still patient having significant pain. Okay. Now coming to rotator cuff tear. Rotator cuff tear, most of the time it happens in the supraspinatus tendon, but the diagnostic tip to think of rotator cuff tear, like maybe one tendon has got torn or multiple tendon. If a patient has got supraspinatus weakness, that means unable to do the shoulder abduction, unable to do the external rotation, and patients also having that painful arc syndrome, if this out of these three, if two is positive, then there is a highly chance, that 98% chance that there is a rotator cuff tear. Again, supraspinatus weakness, so unable to do the shoulder abduction, painful external rotation, and impingement. Okay. For that patient, you do an ultrasound first, and if you find a tear, you send them for surgical repair. Sometimes the subacromial bursa. So if you see over here, see this is the subacromial bursa. Sometimes that bursa can get inflamed and can give a similar kind of shoulder pain. So when you do the ultrasound will be able to say if it is bursitis. For bursitis, there will be a localized tenderness. So if there is a localized tenderness on a specific point of the shoulder, then we think of subacromial bursitis. The treatment can be like, you can even give them a strong painkiller such as Panadine, like paracetamol and codeine. But the very good treatment will be inserting a steroid injection into the bursa. That's usually the treatment. Next is adhesive capsulitis or frozen shoulder. I'm sure all of you heard about it. So adhesive capsulitis it's an inflammation of the glenohumeral joint, which means that inflammation of the shoulder joint, and you know that it has a capsule. If the capsule get inflamed, at some point it can become fibrosed and contracted. So it's basically fibrosis or a contracture of the capsule of the shoulder joint. And if it happens, patient can have a frozen shoulder where all movements of the shoulder can be completely restricted. It is common in diabetic patients. So there are three phases. In the first phase, the patient can't do anything. It's a painful phase. So there will be complete frozen shoulder. Then there is a fibrotic phase of 4 to 12 months, and then partial or complete resolution. So it can take even 26 months. So sometimes closer to 3 years, a complete recovery from this frozen shoulder. So there will be a deep aching pain, constant day and night, and patient will not be able to do anything. So complete stiffness of the arm. The first movement that will be lost in a frozen shoulder is external rotation, and that will follow by all others. How to diagnose? Ultrasound. Okay. For frozen shoulder, there is not much of a treatment that we can do, but initially, if it is initial painful phase, you can just give them analgesics. So that will be the main treatment initially. Bit of physiotherapy can be done. Sometimes we can also do a hydrodilation. So, and sometimes even hyaluronic acid injection can be done as well. Okay? Rupture of the biceps tendon. So sometimes patient can have, like, let's say someone just pulled or lifted a very heavy object and they can feel a sudden tearing sensation in their shoulder or biceps tendon. And immediately the shoulder and the biceps will be difficult to move and painful. And you can even see a rolled up belly of biceps. So it will look something like this. So you can see that this patient, if you compare the both sides, you can see the rolled up belly of the biceps. That's sometimes we can get in a biceps rupture. Okay. So for biceps rupture, active treatment is not indicated, but for young active people and those who do a lot of sports, you need to send them for a repair. Polymyalgia rheumatica we discussed in our connective tissue disorder class, not in this class. Okay. So that's all about shoulder pain. The main thing that you need to actually get from here is how to diagnose rotator cuff tendinopathy. What are the main features of it? How to diagnose adhesive capsulitis. Yeah, so ultrasound, the high resolution ultrasound is the diagnosis for frozen shoulder. Okay. All good, guys. So that will be end of our tonight's session. Next class, we will start with the painful arm and hand. Still, there is a lot to discuss. We haven't even finished the upper limb. Then there is lower limb. It's a lot to go through. Any question? If an older person with main profession involving hands and having proximal biceps tendon rupture, will we go for surgery or physiotherapy? What do you mean by main profession? Main profession involving hands. Just because someone has got a biceps tendon rupture, it might not just restrict their full movement of the hand. Many times it doesn't. Many times patient is fine. So if they can continue doing their activity, then it's fine. Just physio is all that they need. But if it is on the right hand and patient is a dominant right hand person, and definitely for the biceps rupture, they can't do anything, then yes, surgery is needed. Okay? All good, guys. So that's it for tonight. I hope that this is making sense, the orthopedics. There's a lot to go through, but you can see that it's not like you need to be an orthopedic surgeon for it. You just need to get a basic idea and understand what is important for exam. I don't know like why you guys are worried about definitive treatment. Can you fix a degenerative like a vertebra? You can't. So there is no definitive treatment for this. If you are asking about definitive treatment, it is always surgery. Okay? But it doesn't come in exam because it's not about surgery that they are worried about. It's all about if you understand that how you're going to manage such a patient. Okay? So definitive for any kind of orthopedic is surgery. But we would rarely think of surgery in a spondylosis or an osteoarthritic patient unless it is really needed. Okay? Okay, so, and for this one, Dr. Mitra, so it seems like reduction is the best approach for the kind of thing if we can do it. But there are lots of other things that can be tried. Like we can, depends on how bad is the open wound. Right ankle joint, there is a laceration. So just because there is a laceration, wound debridement is not the best approach because wound debridement is only needed if it looks like an infected one. Tetanus, yes, it can be. It is one of the important ones, so which we would do. Given if there was no displacement, then tetanus would be the best option in this case. Antibiotics, reduction, X-ray. Reduction would be the best, in my view. And even if there was an option of giving painkiller, that would be the first. I'll see if we can find out any specific management step by step for you, and then we can discuss in our next class. Okay? All right, guys. Thank you so much. Have a good night. Take care.